Hello, everyone. A big hello to everyone that's online today to join us for another episode of this Arthro School webinar series. So this time, today, we're going to talk about biologics in rotator cuff lesions. So for everyone that's into sports medicine, or more specifically into shoulder surgery, namely rotator cuff repairs and shoulder arthroscopy, I'm pretty sure that all of you have already considered or even used biologics, whether in some type of conservative treatment or along with surgical treatment. So we hope to share with you some important insights from several corners of the world. We're going to have great faculty today. So I'm going to start with the presentation of those colleagues of ours. We're going to have Lucca Lacheta from Germany, who's going to share his thoughts on the biologics and primary aspects of all that's available today and the scientific evidences around it. Then we have from the US, Don Buford. A big thank you for joining us despite the difference in time zone. Also, Murat Bozkurt from Turkey. Thank you again for allowing us to have this great platform, Arthro School, available to all of us. And also Saad AlQahtani from Saudi Arabia, who's going to jump a little bit more deeper into the surgical aspects of biologics in this setting. So I'm going to start with Lucca. Lucca, again, thank you for your participation. We'll start with you. So he's going to talk about cell therapy, the current concepts, evidences, and indications for its usage. So go for it, Lucca. Thank you.
So let's see if this is working. Not yet. Wait a second. One more time. So here we go. And now you should see my presentation. Again, thanks for having me. It's my pleasure to talk about cell therapy. I'm an orthopedic surgeon, so I keep this very practical and what we can already use in our daily business. So when we talk about rotator cuff tears, it's not only about putting anchors and fixing the tendon to the anchor. We have to think about what's the origin of the tear. So we have to evaluate the scapula, what's the shape, do we have subacromial spurs, or we need to talk about critical shoulder angle on the anatomy and biomechanical side, but we also have to think about biology, what's happening on the tendon side. So it's mainly a lack of vascularity, and what's happening to the tendon is that we have a thickening and disorientation of collagen fibers. So this could be one target of our cell therapy. And we have a myxoid and also hyaline degeneration with impaired biomechanical properties. And actually, this area is mainly dead tissue we cannot reanimate. And this will lead to calcification as we see it frequently, and also to impaired vascularity with an increase of blood vessel of the tendon tissue itself. And at the end of this circle, if you just have a look to the right side, it's an hypoxic situation with an induced autophagy of the tissue. So at the end, the rupture site is including dead cells and tissue, what we have to keep in mind when talking about cell therapy. So this is a patient of mine. We look from the lateral side. You can see a massive posterior supra cuff tear. You see it's delaminated. The articular sided layer is very retracted. So a challenging case, not only technically, but also for biology. Sepp Brown and myself, we had the pleasure to write a systematic review almost 6 years ago, and the conclusion of this review was, in terms of cell therapy, there are no procedures proven to work in shoulder surgery. So let's have a look at what happened within the last 6 years. So 6 years ago, when you visited orthopedic conferences and talking about rotator cuff, it all was about mechanical stability, and this will lead to biologic healing. We came from single row to first generation double row. Now we are with cross-linked double rows. However, even if we are more anatomic and biomechanical stable, this is also a patient of mine. This can end up in this situation. She is a young lady, 50 years old, so I didn't expect at all that this cuff tear will fail, and it's also no infection. That was my first thought. So even in young patients, we have troubles with biologic healing. And we also know that when we want to keep the muscle and engine behind the tendon running, we need an intact enthesis. Looking at the re-tear rates, you see from small to medium, large to massive, we go up to 40%. And when it comes to revision repair, we can even flip a coin to guess if it's healing or not. So what can we add from a biologic perspective to improve our rotator cuff healing? When we look at the bone interface, one of our working horse still, it's a simple microfracturing of the tuberosity. What I do first is I burn all the tendon stem, what is left, and then I refraction the bone with a burr to create a flat bleeding underground and open up the bone marrow to have even more blood supply and bone marrow stimulation for better healing. And if you look to the literature, this was pretty clear. We saw in several studies that you can lower the re-tear rate by half, even if we don't see any clinical or functional difference between healed or non-healed cuffs. And what we also observed, when the enthesis healed, we shift the weak link from bone to tendon interface to the muscular-tendinous junction. However, I said this was our working horse. Newer literature supported actually that even with bone marrow stimulation, we cannot lower our re-tear rate. The next spot we can target with cell therapy is the enthesis. We will hear this in the next talk by Dr. Buford. But shortly, 2 slides. I was very skeptic at the beginning, but evidence is getting stronger and stronger every year. And as you can see here in the study by Hurley, especially the large cuff tears, medium to large, they benefit significantly from adding PRP intraoperatively to the rupture side. And when we look to the combination, or which is the best combination of techniques we can add to lower our re-tear risk, then it's the combination of a double repair plus adding PRP. I'm excited for the next talk because I don't know where exactly to put it. There are several studies out. You can inject it to a subacromial space. You can inject it intra-articular. I like to do it to the rupture site. I stop my inflow and then I put it into multiple locations and inject the PRP. But this will be the topic of the next talk. And now we go a little bit into the future and to tissue remodeling. This is actually of interest of our working group at the moment, to stop fibrotic changes during the healing phase. We all know that during the first weeks after rotator cuff repair, we have an elevated fibrosis, and the key driver is transforming growth factor beta 1, as you can see here. But what happened when tissue gets fibrotic. It gets stiff, it loses elasticity, and therefore, especially in rotator cuff repair, it can lead to improved biomechanical properties and re-tears. And we already know from other tissue that less fibrosis leads to improved tissue repair and more elasticity. And that's what we try to target in rotator cuff repairs too. So we were working on this project for almost 8 years now, together with the group of Johnny Hewitt in Colorado. They did great job on showing that blocking TGF-beta-1 will reduce fibrosis in cartilage tissue, in muscle tissue. And then we were looking at the tendon tissue, if it's working also, especially in rotator cuff tendons. And out of an animal study with white New Zealand rabbits, we saw synergistic effects, especially by adding TGF-beta blocker in terms of losartan, an antihypertensive drug in the US, and adding bone marrow stimulation to the tuberosity side. So we took this idea from an animal study into clinical reality. And what we first did is to look up all our patients who had TGF-beta blockers. In Europe, it's valsartan or candesartan, same like losartan in the US, at the time of surgery and afterwards. And we did a retrospective case control study. You see a low number of only 26 patients. And we matched them according to involved tendon, tear size, BMI, age, and so on. And what we found out that we didn't observe any significant differences between clinical outcome. Surprisingly, we saw pain that sartans were a little bit more painful than the control group, maybe because of the difference in follow-up. And we observed a better tendon integrity in ultrasound and MRI compared to the control group. 100%, I always say, don't trust a study with 100%. The number will change probably when we see more patients. But however, we were only able to see 26. So what is the next step? The next step would be a randomized controlled trial, but in Germany, legal-wise, it's super hard to start an off-label study with medication. So you need some evidence before. So before applying for that, we performed a multi-center study or connected to a multi-center study. Maybe you guys are aware of the big Swiss multi-center trial with over 13 centers, prospectively enrolling almost 1,000 patients. And we incorporated our questionnaire about sartan intake. However, also in 1,000 patients, we were only able to identify 63 patients with sartan intake and compared them to the rest of the cohort. And what we observed is, again, no differences at any time point between all clinical outcome parameters. However, when it comes to tendon integrity, we observed the opposite from our prior study, with less integrity in the sartan group compared to the control group. And statistically adjusted, we even saw an increased risk ratio to suffer healing failure of 2.6 for sartans. Though we had a closer look to the data, and of course, what was seen is that the sartans were a little bit iller. They were older in terms of age. They were fatter in terms of obesity. They were iller in terms of the other classification, of course. This was the indication for the sartan intake. Most of them had arterial hypertension. So long story short, hopefully our randomized controlled trial will see if sartans are working or not. But this journey of the TGF-beta blocker is like a little bit exemplary for what's out right now about cell therapy. You find several studies supporting cell therapy and the same amount who showed that there's no benefit. But so far for my clinical practice, what is my take home? First, see what are the problems of the cuff tear in terms of anatomy, biomechanics, look at the scapular subacromial space. Respecting biology, what is crucial for me is not only preparation of the tuberosity and adding bone marrow stimulation, also a debridement of the dead tissue at the tendon stump site. We can improve our enthesis by stimulation with PRP, subacromial decompression, or even bone marrow aspirate like in the US. And what should our target in terms of future science is how we can get a remodeling of the tendon by antifibrotic drugs or other agents, but this will be of greatest interest in the future. Thank you very much for your attention, and I'm looking forward to the discussion with you.
Thank you, Lucca. I think we're going to move a little bit more forward, and we'll place the questions afterwards, after a couple of talks, perhaps, and gather some of the questions that delegates are always are also have already posed. Okay, so we're going to move to Don Buford. Welcome from the US. And he's going to share with us some practical tips regarding the standardization. In fact, trying to find out if we're all using the same thing or not, because as we all know, industry pressures are important. They can change our choices sometimes, and we have to be judicious when deciding what to do, what to choose, and what to give to our patients. So, Don, it's on you now. Thank you.
Well, first, let me say thank you for the invitation to participate. I'm always humbled and honored, and it is not a lie to say that I learn as much as I teach when I do these. Can you see that? Okay, fantastic. So I'm going to certainly build upon what Lucca just presented to us, which was fantastic. I'm going to touch on dosing of some of the more common biologics that we have available to use, and go through some of the recent clinical outcomes that have been published really over the last 12 years. So it's new, but it's not that new. We have results dating back a decade even. I'm based in Dallas, Texas. So if you're ever in this part of the United States, for sure, look me up, give me a shout. My website is texasorthobiologics.com. This is the handout for my talk. If you want to just use a internet browser, it's buford.info/arthroschool26, or you can of course use the QR code, and I can get that to everyone after the this live session if desired. So I'm going to review the evidence, because that's really where most of my colleagues start, which is reasonable. You know, what is the evidence to do something different? Can I really enhance my surgical outcomes? And I'm going to focus, for that reason, on human outcome studies. And again, I'm in the United States, so I'm going to use our FDA's regulatory compliant orthobiologics as of within the past year. And so for me, that means we're going to be talking about platelet-rich plasma. We'll be talking about bone marrow aspirate concentrate. And we'll be talking about the version of adipose that we're allowed to do in the United States, which is not stromal vascular fraction with enzymatic degradation of adipose, but we can do a version called microfat, which is in Europe as lipogems, and there's other companies in the US that do something similar. I'm going to start with platelet-rich plasma. I want to go through some of the evidence, and some of this may be repetitive based on what Lucca presented, but I do want to show people that are dialed into this presentation that we have plenty of evidence to support using platelet-rich plasma to augment rotator cuff repairs. We have enough evidence that the American Academy of Orthopedic Surgeons in the United States has recognized that and put it in their clinical practice guidelines. In 2024, there was this meta-analysis published that looked at 21 separate level 1 studies, very large N, over 1,300 patients. And the summary of this study, despite there being different versions of PRP throughout these various studies, was that with augmenting repairs with PRP, the re-tear rate was 16.5%. Without PRP augmentation, the re-tear rate was 23.6%. And in addition to that metric, patients with PRP augmentation had better constant scores, had lower pain scores, at all times in the group that had the PRP augmentation. And so when you have this type of data, you have enough data to do a meta-analysis, and every study in that meta-analysis is a level 1 study, that starts to become something that all of us should be able to reproduce clinically as long as we're using what I would consider a reasonable form of platelet-rich plasma. These are other studies giving further evidence. And what we're starting to see as we reach consensus on using PRP to augment our repairs is that these studies are from around the world. It's not just one clinic, it's not just one doctor. These are studies being done by multiple talented surgeons and clinicians. And so when that happens, it starts to become something that I incorporate into my thought process because it's reproducible. The first study at the top was published out of Greece, and they looked at 25 separate trials, and what they found overall was very similar to the previously mentioned study, about a 12% decrease in the re-tear risk when you augment rotator cuff repair with PRP. In a study out of China, out of Wuhan, which became famous during COVID, but in this lab, they found a 60% decrease in re-tear risk. And they found that platelet-rich fibrin had no effect on re-tear rates, which is essentially a lower dose version of PRP. And so that raises the question of what dose should I use? And the simple answer that I give to my colleagues when I get asked this question is probably greater than 5 billion platelets. And in order for that to make sense, we have to understand that the dose is the PRP concentration, which we can get off a hematology machine, times the PRP volume that we're injecting. And so where does that answer come from? Why do I say that? This is one of the articles that gives me the confidence to say that. It was published in 2021 in the Journal of Arthroscopy. And this was a very well done level 2 study, 50 patients total studied. They had MRI follow-up of the rotator cuff healing outcomes. And what they documented was that when they used this version of PRP, which is a leukocyte-rich version of PRP, in a single injection, that 94% of their patients showed better scores in terms of functional outcome scores and pain scores by 6 months. In fact, 84% returned to the same level of sports within 3 months. Now, this was a tendinopathy study, not a surgical study, but it's from studies like this that we then take this information and look at dosing for surgical augmentation. Only 7% of these patients required a second injection. So we'll talk a little bit about tendinopathy, but whether it's tendinopathy or surgical augmentation, I think we want to get to at least a 5 billion platelet dose number. I was in a group that published a paper looking at multiple soft tissue applications, and the end result of that analysis, again, across more than just rotator cuff, but across all soft tissue applications, was that if your dose is below about 3.5 billion platelets, then 11 out of 11 studies showed that it didn't help the patient. Whereas if the dose for a soft tissue indication, which would include rotator cuff, is above 3.5 billion platelets, we had 9 out of 11 high-level papers showing that it was a positive or a beneficial thing to do. Patients had statistically significant improvement. And so 3.5 billion is maybe the floor for me in my clinic. I would much rather be in doses that have been documented, like in this study, in the 5 billion range. How do you know the dose? It's the single most important thing that we can control clinically. We have to assume, in my practice, we assume that the patient's starting platelet count is the lowest normal platelet count. Now, I have a hematology machine, but the reason why we do that is a teaching mechanism. Many colleagues and people listening to this webinar will not have a hematology analyzer in their office. And so we have to figure out a way for them to accomplish these doses without knowing for every single patient exactly what the number is. And the way to stay safe and to make sure that you're meeting a threshold is to assume that your patient has a minimum human platelet count, which is 150. If you draw 30 cc's of blood, then that means you're likely going to be under that 3.5 billion threshold that I just talked about. Because when you draw 30 cc's of blood, you're only starting with 4.5 billion platelets, and all of the kits, all of the protocols to make PRP lose some platelets. And so if your kit loses a certain percentage of platelets and you're only starting with 4.5 billion, it is very likely that you will often be subtherapeutic, in my opinion, in your platelet dose. However, if you double your blood draw which is something all of us can do in the office. It's the single most important thing we can do in the office or in surgery. If you double the dose or double the draw to 60 cc's of blood, now you're starting with 9 billion platelets minimum. If you use a reasonable protocol, then now you're going to be at 5 billion platelets or above. And so the tip out of that is draw a minimum of 60 cc's of blood. And that's based on assuming that your patient has the lowest possible platelet count, if that makes sense. If your patient has a platelet count in the 200s or 300s or even 400, you'll be even above 5 billion platelets. And at this point, from what we know about dosing, a higher dose is at this point only beneficial clinically. I want to talk a little bit about bone marrow aspirate concentrate. We have several studies now looking at this bone marrow aspirate concentrate as a potential beneficial biologic when augmenting rotator cuff repair. This study was a registry study, and it looked at a group with PRP, a group with BMAC, and a group with rotator cuff repair alone. And the results in this study, which was done out of the Mayo Clinic in Florida, is that the BMAC patients had 64% fewer revisions at 2 years. PRP patients in this study showed no difference in revisions. And so a little bit of a different outcome for the PRP patients. This was a level 1 study out of the clinic of Dr. Brian Cole in the United States. And they drew 60 cc's of bone marrow to make bone marrow aspirate concentrate. What they showed was that the BMAC group had improved tendon quality by MRI scan at 1 year. And the control group, just like the last study, showed greater re-tears on MRI at 1 year. So this is another study showing evidence that BMAC is a potentially useful thing to do. This is the best study, and it's already 12 years old. This came out of France, out of the office and the clinic of Philippe Pernegal. And the key here is what I've highlighted in the red rectangles. Brian Cole's study that we just looked at, he drew 60 cc's. In Philippe's study, he drew 150 cc's. So over twice as much bone marrow. It's not quite the same as saying the dose is twice as high, but he definitely had a higher cell count, a higher cellular dose, if you will. The other real big key about Philippe's study is where he injected the BMAC. And that's really one of the biggest take-home messages for me. He injected 2/3 of it into the greater tuberosity at the time of surgery. He injected the other 1/3 into the tendon, like Lucca showed, at the tendon bone interface, and some into the subacromial space. But the real novel approach and the novel idea that he had was that he injected the bone. And why did that work? Probably because there's healing from the bone. Mesenchymal stem cells are in the bone. And if we can put essentially fresh stem cells from the iliac crest, concentrate them and put them back in the greater tuberosity, he showed amazing outcomes. 100% healed at 6 months. The real big outcome that I'm interested in is 87% were still healed a decade later at 10 years. In the control group, only 67% were healed at 6 months, and less than 50% were still healed at 10 years. And so this is still the best paper published showing that using bone marrow aspirate concentrate can be beneficial when you augment cuff repairs. And it's the best paper published for any orthobiologic augmentation. A brief word about microfat. This is just a video showing how we can get microfat in the office. That's Dr. Ariana Demir's. The literature on microfat is not as robust as PRP or bone marrow aspirate concentrate. We have this 2017 study that's relatively small, 28-month MRI follow-up. The microfat re-tear rate is lower than the control group rate, so that kind of matches PRP, certainly matches BMAC augmentation. They didn't show any differences in clinical outcomes in terms of pain or function, and that may just be the result of it being a relatively small study. This paper in 2022, this was another mechanical technique in terms of how they process the adipose tissue. This was injected into the subacromial space, and what they found here was really no difference in failure rate or for that matter in complications. But again, as you can see here with the numbers involved, there's only 44 patients. It's relatively small and most likely underpowered in terms of having statistically significant outcomes. This study looks at evaluating adipose with cuff repair, and it's in process. It hasn't really been published yet, but I do know that the authors are still collecting data as most recently as I checked with them. It's a N of 30, and they're using microfat to augment cuff repairs. And so we await the outcomes of this study. One of the things I'll mention, and then we'll close, is that A lot of us are using graphs because we have evidence showing that graphs improve outcomes. I prefer to use a graph that has structural strength at time zero, as opposed to a graph that's pure collagen and doesn't have any structural stability. And one of the things with this particular implant that's available in the United States is I can actually soak this collagen PLLA composite graft with a biologic, whether I choose to use PRP or bone marrow aspirate concentrate. And this graft that you see here will hold about 80% of its weight in liquid. And then I can suture that down on top of a cuff repair, whether it's single row or double row. And this is still in the anecdotal stage. We don't have long-term outcome studies looking at adding a graft and soaking the graft with biologic, but to me, it makes good sense, along with putting the biologic into the greater tuberosity, into the tendon bone interface. So the take-home points: do your biologic augmentation at the time of surgery. BMAC has a better reported long-term outcome than PRP. PRP can certainly decrease re-tears, but dosing is important. Get your dose above 5 billion platelets, and the simple way to think about that is get your blood draw to 60 cc's or better. That will protect most of us that don't have the ability at the time of surgery or even in the office to run a hematology analysis. Adipose may be useful too, but at this point, I think we need more studies to put it at the same level as PRP and BMAC in terms of our clinical outcome studies. So thank you very much. Again, thank you for the invitation to participate, and I will stop sharing my screen and be available for questions later.
Thank you, Don. So I'll just ask a couple of questions for you and Lucca before we move on. So first question I'd like to ask you, Don. So do you measure injection, or do you assume there's a minimum amount of PRP or concentration of whatever you're using when following those guidelines you shared? Or do you still measure them every time?
In the office, I measure every time. So if I'm doing tendinopathy procedures where we're using PRP or BMAC in the office, we have a hematology machine, so we have the ability to measure every time. In surgery, in the surgery centers where I operate, that would be, a difficult thing to do procedurally because they don't have the same type of 3-part or 5-part differential machine. And so I account for that by making sure that I'm drawing either 120 cc's of marrow, or I'll even draw 120 cc's of blood to make PRP. Because I'll give you another tip that wasn't in my talk. My current protocol, which we're about to publish hopefully before June this year, is not only are we injecting, now this is PRP, we're injecting into the joint, we're injecting into the tendon bone interface and into the subacromial space. So that's what we're doing clinically in the office. With BMAC, I'm using Dr. Hernigau's technique, which is into the bone also. So I do think it's important to put some into the joint. A lot of these patients have some baseline, arthritic changes, so it doesn't hurt to do that for them at the time of surgery. And we know that especially with a full thickness tear, there's an articular side also. So putting it into the joint allows whatever the biologic is to affect that articular side too.
So I'm assuming that you do those measurements in your office because you can. So mainly for academical reasons. If you want to be practical, you don't have that easy of an access to those measurements. Would you advise still to do those measurements or just follow those guidelines to any general surgeon?
Yeah, I think I would follow the guidelines of, it's partly in jest when I lecture, but I would say 60 cc's is the minimum. That's the ante. If you're going to play poker, you have to put in 60 cc's of blood to get your levels to a point that you don't have to worry about not having the hematology machine.
Okay, good. And for Lucca and you too, Don, following all the information you shared and your experience, how do you select the patients during surgery to inject? Do you inject the PRPs in all of them by default, or do you select them following criteria, any definite criteria?
Well, right now we just use PRP for study reasons because the big issue in Germany is to get reimbursed during surgery, and this is not possible for all patients. So right now we use it for studies, and we focused on medium to large cuff tears postsuturally. And these patients are getting PRP, and we follow up and see how it's working in our own series, if we can reproduce the results we saw in the literature. Yeah.
Are you using any kits provided by the industry, or do you have all the setting, based in the hospital of yourselves?
No, we're using industry kits, yeah.
That can interfere with the decision, I suppose. Do you believe? I mean, regarding in all of the patients or just selecting them? Because there's an extra cost. What I mean is when you're using industry kits, you're probably conditioned by the fact that the costs are probably higher. So do you feel that may have some interference in your selection?
Definitely, yeah.
Don?
Yeah, so I present PRP to all my patients with full thickness cuff tears because I think the decrease in re-tear rate is significant. Although if a tear is smaller than a couple centimeters, I'm still a single row guy just because that's the way I was brought up. But so in other words, for me, if it's one triple loaded anchor, 2 centimeter or smaller tear, the success rate there in multiple studies is about 93% at 2-year MRI follow-up. So I'm not as concerned about those patients unless they have some other comorbidities. As soon as the tear gets to a point where I'm looking at the MRI scan and there's retraction, there's maybe muscle atrophy, it's a 2 centimeter or greater tear anterior to posterior, then I present BMAC and PRP to those patients. And I think BMAC is if someone says, what's the best thing you know about, I would say BMAC. And if they say, what's the best way to do it? I would say into the joint, into the bone, into the tendon, and into the subacromial space. And we draw 120 cc's of BMAC to do it. So I really think that there's a benefit to that. None of us may reach Hernigau's amazing results of 100% healed, but even if I can get those 4 centimeter tears, a higher success rate, then I think it's worth it. Those are also the same patients, by the way, where I'm having a conversation about grafts. So they go together.
Okay, thank you, Don. So let's move on. Now it's time to listen to my friend for over a dozen years, Murat. Murat, thank you. So are you ready to talk on biologics in cartilage lesions of the shoulder? What can we learn from the experience on the knee? Because you've got a lot of experience on the knee, also on the shoulder. How can you shift all those evidences you have on the knee to the shoulder?
Yeah, thank you, Nuno. I think it's a really, the smart topic for me because I'm a knee and the shoulder surgeon. Today I operated till to now 2 knees and the 2 shoulder arthroscopies, and then I was talking with my the friends in the OR and about this topic, and we discuss a lot. What are the common for the both joints, and then what we learned from the knee to just adapt to the shoulder. And actually, glenohumeral joint is completely different than the knee joint for the kinematics, for the stability, for the shape, for the the morphometry and everything. And that's why for the cartilage lesions and the treatments, treatments of the shoulder cartilage lesions and the knee lesions are now not really comparable because for the knee cartilage lesions, more than 25 years biological research also are available. And then we have some standardized techniques. And also for some clinical applications, there are some strong evidence. And we have already some registries and the outcomes for the knee. On the other hand, for the shoulder, it's not. But that's why actually glenohumeral joint articular cartilage did not significantly differ from the ankle and the knee with regards with the, proteoglycan synthesis and the gene expression. And actually, it did differ in the histological appearance in normal state. And these data suggest that glenohumeral joint can show signs of the early osteoarthritis in older, decreased individuals with the histologically and the macroscopically normal appearing knee and the ankle cartilage. But however, more work is needed for the larger numbers of samples to further understand the biology of the glenohumeral joint articular cartilage and responses to the catabolic cytokines. Actually, glenoid and the humeral head cartilage also is a little bit different. Cartilage thickness of the humeral head and the glenoid has a complementary relationship. Humeral head cartilage is thickest in the centralmost portion of the, becomes asymmetrically thinner superiorly and inferiorly. Reciprocally, the glenoid cartilage is thinnest in its central portion, and the glenoid cartilage is thicker than the humeral head cartilage and varies more widely from the maximum to the minimum. These results can be used further inform the prosthetic design and also some osteochondral allograft transplantation. Etiology almost the same. Predisposing factors are there are some specific predisposing factors for the shoulders. Actually, cartilage injury in the index episode of dislocation, glenoid rim impaction, fractures, heel sacs lesion, age at time of the first dislocation, recurrent instability, presence of the rotator cuff tear, and the time period from the first dislocation and the anterior stabilization. Actually, rotator cuff tear also is really important. The reason of that's why we learned from the knee for treating the cartilage. It's really important to know the stability and the alignment and the congruence of the joint. That's why you have to treat surgically, get some stable joint with the congruent joint and the good alignment of the joint for before treating the cartilage. And as a knee surgeon, sometimes we are in the ACL reconstruction, we are just leaving some remnants, and now we are discussing arthroscopic rotator cuff repair technique incorporating remnant tendon insertion. It's really good for the proprioception, and also it is really important to get some good healing as well. And of course, we are using some scaffolds, and the Don and Lucca showed some the augmentation, biological augmentation. It is really important. And for the shoulder cartilage lesions are always underdiagnosed, ignored, limited intrinsic healing, and the no-go standard yet. And can be translated to this shoulder, same biology and the different biomechanics. That's why weight bearing, larger defects, easier access, and strong data with the knee. But the non-weight bearing and smaller lesions and technical difficulties and limited data at the shoulder. Actually, that's why we are treating the cartilage lesions. We are using the same methods for the knee with the microfracture, mosaicplasty, and everything we are treating. And also we are using the same, classification systems for these cartilage lesions. But we must know, we must adapt this cartilage treatment, but not copy. That's why we were talking about the BMAC, fat tissue, some SPF, some exosomes and everything to treating the glenohumeral joint, the cartilage. Of course, there are a lot of articles in the literature about that, but actually there is not really, enough data to use and then to show the proven of the efficiency of all this treatment. But of course, we are using the allografts with the augmentation with the BMAC and the SVF and the other PRP like a biological orthobiological treatments. Actually, osteochondral allograft transplantation in the shoulder is getting much more popular in the literature in our clinical. I'm also performing this technique for the shoulder cartilage lesions. It's really good, and then I think you need a good tissue bank. If you don't have tissue bank, you can use some iliac bone grafting and some cartilage treatment technique like a means cartilage with the cylindric osteoperiosteal iliac graft of you are getting, and then we learned in the mosaicplasty in the knee, and then we are also now performing in the shoulder cartilage lesions, allografts, autografts, and means cartilage techniques. But for the means cartilage techniques, now we were using the handmade, and then after that we get the autocart to get the, the some means cartilage, but viability of the cartilage, the cells is not really are not really good for in the means cartilage with the graft net. That's why I'm using the hybrid technique of the means cartilage. Actually, there are numerous joint preserving surgical options for the treatment of the subchondral lesions involving the glenohumeral joint in young and highly active patients without clear consensus as to which approach provides the best outcomes. Actually, there are some systematic reviews, and you must think that the arthritis progression. That's why you must try to do you must evaluate the patient individually, and then you must try to save the joint. What are the future directions? Cellular therapies, tissue bank for the shoulder, gene modulation, injectable scaffolds, and the registry reports. But it's really, I'm so sorry, the shoulder is where the knee was 15 years ago for the all these things. As a take-home message, biology really matters. Knee teaches us principles. Shoulder needs an adaptation, combine mechanical and the biology. Respect the biology, respect and save the shoulder, and personalize your treatment. And the motto is first of all, before doing the arthroplasty, tomorrow I will do the two shoulder arthroplasties, and always, but I'm trying to save the shoulder. Thank you very much.
Thank you, Murat. Thank you for sharing your experience. Just a quick question. So definitely you have more experience in treating these cartilage lesions in the knee. We all know about that. Do you feel or do you find the same rate of success in the shoulders you treat with this type of lesions as you find in the knee, or do you find any differences, and why is that? We're talking about a weight-bearing joint versus a not weight-bearing joint. So what do you have to say regarding that, the rate of success between the two?
Actually, I was performing the open surgeries for the cartilage, large cartilage defects in the shoulder, but now we have the enough experience for the knee joint to do arthroscopically. Actually, both joints are completely different. Mechanically, alignment, congruence, and the stability and everything. Actually, now I'm trying. We are ignoring, and we are focusing the rotator cuff stability or labrum lesions, but we are ignoring some glenoid, the cartilage defects, and also for the humeral head defects. And we are sometimes ignoring the large heel sacs lesions with the extending the cartilage. Now we are learning, actually. I'm learning too. That's why we need much more data, much more experience for the shoulder cartilage lesions. We can do some cellular therapies like a BMAC, SVF, and the other cellular therapies, but we must replace sometimes osteochondral tissue in the shoulder, like in knee joint. But
okay, thank you, Murat. So let's move on, and now let's move further east in the globe, and let's have Saad AlQahtani joining us from Saudi Arabia. Welcome, Saad, and thank you for accepting the invitation. So it's on you now.
Thank you very much, guys. Do you hear me?
Yeah, we can.
Good. So after these great talks, I'm going to talk about patch augmentation and tendon grafting and surgical repair. So we'll start with the case. 64 years old male who's presenting with right shoulder pain for more 9 months. He's diabetic, dyslipidemic, smoker. His classical exam with some weakness in external rotation. He failed physiotherapy and injection. You can see his MRI, both coronal and sagittal, where there is a medium-sized tear and maybe a small atrophy. So we treat him with a double row rotator cuff repair, and given his age, his comorbidities, uncontrolled diabetes and smoking, we elected to augment our repair with a bioinductive augmentation. In this case, we used the BioBrace. It's just a classical double row repair. Then we augment that with two lateral row anchors. So these are case just to start our talk. As you know, rotator cuff tendon quality decreases during lifetime, which means risk of degenerative rotator cuff tears increases over time. The two challenges that we face in rotator cuff repair is biological and mechanical. As you all guys know, suture tendon interface remains the weakest point of rotator cuff repair. Double row repair, which we call suture bridge, increase the mechanical repair strength, but it increase the risk of type 2 failures at the musculotendinous junction. Most of rotator cuff repair, if you treat that, you know that most of them, if they're going to fail, they will fail with the first 3 months, which mean it's mainly a mechanical stability problem. Considering the increasing number of degenerative cuff tear, biological and or structural batch augmentation might potentially decrease the rotator cuff repair failure, which mean on the short term, or re-tear on the long term. So when we look into the rotator cuff repair augmentation and batches, we have the biological, and we had a great talk by Dr. Buford regarding the BMAC and the BRB. We have the structural, which is the synthetic, and we have what we call the biological enhanced batches, which can be an autograft, allograft, or a xenograft. These are some examples of the available batches in the market. The Arthroflex from Arthrex, we have the Regenetin and the BioBrace, and almost every company now have their own patches, either synthetic or bioinductive. This editorial commentary by Grant Skeris is really very nice, where they call the biologically enhanced patches augmentation the perfect marriage of mechanical stability and biology for rotator cuff healing. Unfortunately, not yet. And if you read it, the most important, I think, sentence was, one truth that is clear is that to justify this massive increase in the cost of the operation, a clear benefit must be demonstrated, and none was shown here. And this is, I think, an eye-opening for all of us. So for us on healthcare, we know that value is defined as quality over cost, and our goal is to have a high quality, low cost healthcare so we'll be able to provide the best value. So for no doubt, we know that this patch augmentation is really going to increase the cost, but let's now go and see what's about the quality. So if you look into this systematic review and meta-analysis, when they look into the benefit of the batch augmentation of rotator cuff repair, they notice that really the re-tear rate is really decreased from almost 42% to 20%. So this is almost 50% decrease on the re-tear rate. But when we look into the clinical outcome between patients where patch is used or not, there was no difference. So there is decrease in the re-tear rate, but this is not translated into any clinical outcome, especially on the short term. This study, which is a very good study by McWell, where they look into augmentation of a double row by a bioinductive collagen, and they look into both the Sugaya grade or the re-tear, and also there was a very huge decrease on the re-tear rate from 25% to 8%. But when they look into the ASES score, there was no difference between two groups. So also confirm the same thing, that the re-tear decreased, but it's not translated into any clinical outcome. This study is also looking into the batch augmentation, but for this set of patients, they look into the partial thickness rotator cuff tear, 7 studies, almost 500 patients. What they noticed that augmentation really associated with increase on the tendon thickness and improved functional outcome, but they noticed that almost up to 25% suffer from stiffness and adhesive capsulitis, and we have to keep that in mind when we treat patients with bioinductive patches for partial thickness tear. What about revision cases? This study, it's a small study. They have 38 patients follow up to 3.5. They have 6 failure in the bioaugmentation and 8 failure in the non-augmented group. So the conclusion was bioaugmentation with bioinductive collagen patch has a similar failure rate and patient-reported outcomes compared without bioaugmentation sitting on the revision cases. Because, sometimes we said we're going to use it in revision cases. This study showed that there is no difference. What about cost analysis? This is by Peter Chamber when they look into the cost analysis of dermal allograft. It's a matched cohort study between 2014 and 23 in a single academic center. They noticed that the cost of the surgery increased by almost $5,000. So the cost is really there. It's not a small amount of money, but to justify that, we have to translate it into a really patient outcome. This is a recent study. I think it's a very important study that was done by Muin from Canada, where they did a meta-analysis looking into the structural augmentation of rotator cuff repair. They have 12 randomized controlled trial, 12 cohort of a full thickness rotator cuff tear. The result is very good. They have 35% lower risk of re-tear with a structural augmentation versus standard repair. The biggest effect was with allograft augmentation. The re-tear was confirmed with ultrasound or MRI, but the problem is there was no meaningful difference in the short-term patient-reported outcome, either pain, ASES score, or constant score. So the conclusion is the augmentation improved the structural integrity, but patient may not really feel the difference early, and we still need to define who benefit most of these patches. One other way of patching is augmentation of the cuff with the biceps, what's called either a biceps rerouting or biceps transposition. Dr. Larry Field called it the bio-SCR, where you really translate the biceps posteriorly into the footprint, then you augment and repair the cuff over it. There is multiple ways. Either you do a tenotomy, you do a tenodesis, you leave it in the groove, you cut it from the anchor and put it on the footprint. Multiple ways, but the conclusion is it's always there, especially on the primary cases. You have the biceps and you can really use it to augment it. And their conclusion was incorporating a transposed biceps tendon into the repair of a massive rotator cuff, which called bio-SCR, result in a significant clinical improvement with low complication rate. So as you all see during these all studies, the tear really decreased, the thickness of the cuff increased, but the clinical outcome on the short period or the short term is not really significant. But we all know that patient on the long term, patient who heal their rotator cuff do better. So maybe we don't see benefit on the short term, but maybe on the long term, because these guys are really healing their cuff, they will have a better outcome on the long term. This is a very good study with 800 patients, and they showed that the patient who really heal their cuff have a better ASES score compared to non-healing group. So what about the evidence-based clinical practice guideline by the American Academy, which was published last year? It's really supporting the use of the patch. So for the dermal allograft, the use of a human dermal allograft to augment rotator cuff repair can lead to a lower re-tear rate and better patient-reported outcome, but they advise against the porcine allograft. So the evidence is moderate and the strength of recommendation is moderate. And when they look into the bioinductive implants, the recommendation was the use of a bioinductive tendon implants to augment rotator cuff repair or as an alternative to non-augmented repair can lead to a lower re-tear rate and a better patient-reported outcomes. High evidence and strong recommendation. And I think these guidelines really support the use and really help the surgeon to use it, because it's really now in the guideline of the rotator cuff repair. So in summary, using a patch compared to no patch have equivalent outcome, mainly on the short term. It definitely has a lower retear rate. It increases the tendon thickness and quality, but you have to keep in mind that there is almost a $5,000 increased on the cost of the surgery. So is it worth the cost? I think maybe for the long term, yes. And for me, the indication to use the patch at this time is older patient where they have a poor tendon quality, diabetes, smoking, revision cases, or when the ROHI score is more than 7, which will give you that there is a high failure or non-healing potential. Thank you very much.
Thank you, Saad, for sharing that talk. Great overview of all the science that surrounds this topic. Now, we all know that we're still missing some strong evidence regarding cost effectiveness of these choices. How exactly do you choose your patients? I mean, you've just shared in your last slide your criteria, but how often do you actually go into these choices, and which particular patch would you prefer and why?
So as you know, it's very hard to justify the cost, especially most of the patient I treat is insured patient, and the insurance company very rarely that will cover it. And most of the time, the patient will pay from their pocket for these patches. So I don't really use it a lot, but I try to keep it on the room when I have a revision cases, when I have a very poor quality on the MRI, when the patient really is very old, sometimes renal failure or having a rheumatoid. But always in these type of cases, I'll have it around, but I don't use it all the time. If there is a biceps, to be honest, my go-to now is the bio-SCR or the biceps rerouting, where I transpose it posteriorly, then I put the cuff over it. So I would say maybe 1 in 20 cases I'll use a patch. And if I use a patch nowadays, I go with the BioBrace because it will provide both structural stability, and it's a bioinductive because it's a high porous type 1 collagen with the BLA, so it provides both structural and some bioinductive properties.
Thank you. So you're using it to reinforce repairs. So do you think there's actually room in your practice to use these augmentations in partial bursal tears? Because there's currently evidences that it can help, and it's the first choice for many surgeons that are fond of using these augmentations. So in your practice, do you find room?
In my practice, I don't use these patches for partial tear, and it's merely for insurance reasons. The company will never pay for that. We had that study about the partial thickness. The problem is there will be up to 25% some stiffness. I did a couple of cases, and there is more risk of adhesive capsulitis.
Yeah.
But currently, I don't use it for partial tear.
Okay, thank you. So just before, yes, Don, I was just about to ask the rest of the faculty if there's any burning question before leaving. Yeah.
I guess I'll start. So that last question about partial repairs, that's something that has been very interesting to me over the last 8 to 10 years. And it's not out in print yet, but I can give you the hot off the press data, which is by using bone marrow aspirate concentrate in the office and using ultrasound guidance. And these are people with tendinopathy, tears from 30 to 85%. We no longer say, come back when you're ready for surgery and either complete the tear or put a patch on. We inject BMAC into the joint, into the bone, which can be done in the office quite easily, and into the tendon, about 1 cc in the tendon and some in the subacromial space. With those locations and with that biologic, 80% of our patients are now 7.5 years out without converting to surgery. So that means
any stains on the carpet.
No, we'll be okay. We'll be okay. I have an 18-year-old that loves cleaning up. But But so 1 out of 5 still goes to surgery, but that means 80% of the patients that many of us would have operated on, we can do that in the office now. There's a cost associated with it, but you can make BMAC on your own for under $100. If you have to use a kit, it's usually under $1,000. That's always going to be cheaper than surgery for these tendinopathy situations.
Thank you, Don. Any other questions from the rest of the faculty?
Just
comments?
Nuno, I want to ask the questions to Lucca and Don. Actually, I know it's not allowed to use the BMAC in Germany, actually, but I want to learn their opinion to mixture of the BMAC and the SVF or the fat origin stem cell together, because in one side is just the number of the cells is really good, the other side quality of the cells will be good. And we have some studies also. I'm using the osteochondral allograft soaking with the both the stem cells. What do you think about that, both Don and Lucca?
Don, I think you can answer, because I actually have no experience with BMAC. We had some cooperation with Gasma Soccer in Connecticut back in the days, but these were just laboratory works. So in clinical practice, I'm not the right guy.
Well, one of the things that I always have to remember when I'm talking, especially with patients every day, is these are different biologics. And it sounds kind of silly to say, but the plasma in bone marrow is different from the plasma in blood, which is different yet again from adipose. And so combining these biologics makes good biologic sense, because with a biologic made where you've concentrated plasma in BMAC, and I'll go you one step further, you concentrate and then filter the plasma to further raise the concentration of some of the large proteins like A2M, IRAP, even fibrinogen, which may function as a scaffold if you're using it in or out of surgery. You get the benefit of that plasma component that's different from adipose. Adipose may give you a more cellular content, like you talked about. And so I think it's a fantastic avenue of clinical research. Absolutely.
Great. So to wrap up all this, thank you again for your presence. Saad had to leave because apparently he had a bunch of med patients waiting for him in his outpatient clinics, because there was this misunderstanding regarding the time zone. But so he's left. But he also said thank you and loved being present with all of us. I would like to tell you that we've been over 125 participants from 21 countries. And surely there's going to be a lot more watching this, because this is a webinar that's going to be available online on the After School platform. So again, thank you, and we will all keep in touch. I'm sure that I'm sure I'm going to meet Murat and Lucca very soon, because we meet a lot in Europe, and perhaps one day I'll meet Don in his office in Texas, because it's really appealing, all that you've shared, and the experience that you have. So if you're into these topics, share these webinars and make them popular among our community, because these were really invaluable information available to our peers. Thank you. So time to leave, time to work for those who are working. Thank you, Don. Thank you, Lucca and Murat. Goodbye. Take care.
Bye-bye.